Good day. I am Brian Hoffland, President of Research to Prevent Blindness. Welcome to RPB's Lunch and Learn, Eye on Glaucoma. Research to Prevent Blindness is a leading nonprofit organization supporting eye research directed at the prevention, treatment, or eradication of all diseases that damage and destroy sight. RPB was founded in 1960, and over our 60-year history, we have awarded more than $383 million in research grants to the most talented vision scientists at the nation's leading medical schools. As a result, RPB has been associated with nearly every major breakthrough in the understanding and treatment of vision loss. In today's educational session, our first of 4 Lunch and Learns, you will hear from 2 RPB-supported early career and talented scientists about glaucoma pathology, disease management, and new research directions. One of RPB's marquee programs is the Career Development Award Program, which provides key support of $350,000 over 4 years to promising scientists early in their academic careers to anchor and accelerate their research careers so that they can pursue the research topics about which they have passion and that they have sustained time to pursue these topics without having to take time to chase every funding opportunity that comes up. Our 2 speakers today have received the RPB Career Development Award within the last 5 years. And our moderator for today's session received an RPB CDA in 1999. We have funded 223 CDAs since the program began 30 years ago. And the CDAs are sort of a who's who of vision science. CDAs go on to make breakthrough discoveries, and they collectively have gone on to garner over $1 billion in federal research funding for a 25-to-1 return on investment for RPB. RPB CDAs chair many of the top ophthalmology departments in the nation and lead some of the field's premier research organizations. For example, Dr. Michael Chang, recently named the new director of the National Eye Institute, received an RPB CDA in 2005. But getting back to today's moderator, let me introduce her. Cynthia Grosskreutz, MD, PhD, is Vice President and Global Head of Ophthalmology at the Novartis Institutes for Biomedical Research, where she directs drug development for eye diseases, including glaucoma, retinal disease, dry eye disease, and more. Prior to joining Novartis, Dr. Grosskreutz was at the Massachusetts Eye and Ear Infirmary, Harvard Medical School, where she was co-director of the glaucoma service and headed a glaucoma research laboratory. She has been on the Harvard Medical School faculty since 1994 and is an associate professor of ophthalmology there. After more than 25 years in clinical practice and academia, she is now playing a leading role in drug development for eye diseases. Dr. Grosskreutz has an impressive list of accomplishments. RPB is proud to have supported her early in her career with the RPB Career Development Award, but also later on with the RPB Lew Wasserman Merit Award. Dr. Grosskreutz will introduce our 2 speakers for today and moderate the Q&A session at the end. Each speaker will speak for about 20 minutes, and I will serve as timekeeper. I will give each speaker a warning at the 18-minute mark. We want to make sure that we have time at the end for a robust Q&A. Again, welcome. And thank you to all of you for supporting RPB and making this research possible. Dr. Grosskreutz, take it away.
Thank you very much, Brian. It's a pleasure to be here today and also a pleasure to support the organization that I think has been so important in many of our careers, including mine, for doing research into areas such as glaucoma, where there continues to be such an intense unmet medical need. Before I get to introducing our speakers today, I just want to remind everybody that we will be taking questions at the end. The speakers will speak. And in order to ask a question, please look down at the bottom of your screen, and you'll see a Q&A box there, which will be live throughout the entire event. So you'll be able to type your questions into the box, which everybody will see. And certainly if you think of a question during the presentations, put them there and know that those questions will be addressed at the end of the presentations. So I'd like to introduce actually both of our speakers now before their talks. Our first speaker will be Dr. Paula Ann Newman Casey, who is an assistant professor of ophthalmology at the University of Michigan and an active clinician at the Kellogg Eye Center there. She specializes in medical, laser, and surgical treatment of glaucoma, as well as cataract and anterior segment disease. Her research investigates how we can leverage technology to extend the healthcare system's reach by helping patients better self-manage their own chronic ophthalmic conditions, especially of relevance during COVID. She has received significant grant support funding for her work, including a 2016 RPB Career Development Award. Our second speaker is Dr. Melita Margeta, who is an assistant professor of ophthalmology at Harvard Medical School and a physician and surgeon at the Massachusetts Eye and Ear. She specializes in medical and surgical management of moderate and advanced glaucoma. Her research focuses on the development of novel neuroprotective strategies in glaucoma. She has received many prestigious awards and grants in support of her research, including a 2019 RPB Career Development Award. So I will hand it over to Dr. Newman Casey and very much look forward to hearing your talks. Thank you.
Good afternoon, and thank you for giving me the opportunity to share my research today. I'm going to pull up my talk here. Okay, so I'm delighted to discuss population and patient eye health, how to take control of glaucoma at this Research to Prevent Blindness Lunch and Learn. These are my financial disclosures, which include a Career Development Award from Research to Prevent Blindness, whom I'd like to thank for supporting this work. So I want to set the stage for our discussions today by getting a clear description of what glaucoma is. And this is a short video that I created as part of my research in glaucoma self-management support to help explain what happens in the eye with glaucoma. Primary open-angle glaucoma is the most common form of glaucoma. Over time, the drain of the eye stops working very well. This leads to a gradual increase in eye pressure, and the eye pressure slowly damages the optic nerve. The optic nerve acts like the electricity cable that connects the eye to the brain. When it is damaged, it can no longer bring strong vision signals to the brain. So we'll get into exactly how sight is affected and what we can do about it in this presentation. But first, I'd like to take a look at who glaucoma affects and why. Glaucoma is the second leading cause of irreversible blindness worldwide. There were 61 million cases of glaucoma worldwide in 2010, and of those cases, 8.4 million people were bilaterally blind. In the United States, less than 2% of the population in their 40s has glaucoma, but the prevalence of glaucoma increases substantially as people age to an 8 to 12% prevalence among people in their 80s. With the prevalence among African Americans being at the higher end at 12%, and the prevalence among whites being at 8%. We live in a world where people are living longer and longer, and so the burden of glaucoma will only increase as our population ages. The prevalence of glaucoma worldwide is projected to increase from 60 million in 2010 to 79 million in this decade. So I'd like to show you why glaucoma has been nicknamed the silent thief of sight. And I think this might become slightly technologically difficult as we jump to another website. So please let me know if you're not seeing a new website. I might have to go between it. Okay,
We are seeing it now.
wonderful. So what I wanted to show you was something we created to demonstrate to patients what happens with glaucoma when it's untreated over time. And so we tell them that side vision is lost first and gradually more blind spots develop, but they really may not be noticeable because the central vision remains fine until the disease is very advanced. So because vision is lost so slowly over many years, some people think that glaucoma is not very serious. But we know that glaucoma is serious, and to show people why, I'm going to show you how one patient's vision changed over 10 years without treatment. And we modeled this after a series of visual fields taken over 10 years. But we do know that you can control glaucoma by taking your medications and following with your doctor. So this is in year zero, before the glaucoma started, what a person might see driving down the street. And I'm going to play a video. I think it's difficult to interact over the Q&A in the participant chat room, but what I want you to see is that there's something that went missing in this person's blind spot that they really didn't notice. And unfortunately, what it was a pedestrian crossing the street as they were driving, because you don't notice what you can't see. So that was year one. And as we go down the timeline, more blind spots develop, and this is year 3 without treatment. Now the patient is having more noticeable blind spots, perhaps to the observers in the room, but still there's many people who don't notice that, there was a semi in the road that they didn't see as they were driving. And now we're going into 5 years without any treatment for glaucoma. And to us, the scene may start to look a little blurry, but the person still thinks that they can drive just fine because they're seeing, or at least they think they're seeing, everything. And now I'll show you what they're not seeing and what's obscured by their blind spots, which is now a number of vehicles and a pedestrian. And so at the end of 10 years, things really do look blurry, and the person realizes that they are having a hard time seeing and that maybe they should get some help. So this is why glaucoma has been nicknamed the silent thief of sight, because this vision loss is so slow and subtle for many years. So there are disparities in glaucoma prevalence and outcomes. African Americans are 3 times more likely to have glaucoma, 5 times more likely to have unilateral blindness, and twice as likely to have bilateral blindness compared to whites. People with a household net worth of less than $25,000 are more likely to develop glaucoma compared to those with a household net worth of over $100,000. Decreased trust in the provider is another important barrier to care, especially among minority populations. Dr. Muir and her colleagues demonstrated that compared to white patients, African American patients with glaucoma-related blindness had less trust in their eye care providers. But effective treatments for glaucoma are available. The recent United Kingdom glaucoma treatment study assessed the effect of latanoprost, a once-daily eye drop medication, compared to placebo in early glaucoma, and demonstrated a 56% decrease in glaucomatous progression in the treated group over just 2 years. 89% of patients with glaucoma are treated with eye drop medication to control their disease, but laser and surgical treatments are also available. So who should be screened? Anyone over the age of 65, African Americans over the age of 40, and anyone who has a family history of glaucoma should be screened at the age of 40 or 10 years before their family member was diagnosed, whichever age is younger. So how do you get screened? You get a complete dilated eye examination with an eye care provider. And if an eye care provider looks at the back of your eyes and thinks your optic nerve looks suspicious for glaucoma, they will order additional tests. Imaging tests to assess the structure of the optic nerve, and visual field tests to assess the function of the optic nerve. So what is your eye care provider looking for? You can think of your optic nerve like a donut. All donuts have a hole, just as every optic nerve has an opening in the middle. A good donut has a lot of donut and a little hole, and a healthy optic nerve has lots of healthy tissue around a small hole or cup. In glaucoma, the holes get bigger over time, and so there's less healthy tissue to conduct vision signals from your eye to your brain. I'm about to show you some images where an optic nerve started out as healthy and developed glaucoma over time. Here, the cup is small, but the cup gets larger and larger as time goes on, and this person develops glaucomatous damage. A very common test to assess the structure of the optic nerve is an optical coherence tomography, or OCT test. The OCT maps the health of the optic nerve. It measures how thick the tissue is that feeds into your optic nerve. You can think of the tissue as like the donut dough. Less dough is a less healthy optic nerve. A less healthy optic nerve has more trouble sending vision signals to the brain. You read the OCT map just like you read a traffic light. Red means an area of damaged tissue, yellow means an area of possible concern, and green means an area of healthy tissue. A visual field test creates a map of your vision. It measures how well your optic nerve is functioning. It measures your peripheral or side vision. Sometimes people find this test frustrating. Make sure to let your provider know how to make you the most comfortable. This test is important because it helps your doctor map areas of glaucoma damage. In the visual field test results, small blind spots are shown by the black spots on the visual field tests. Your doctor can compare these results to a typical visual field map and to your own, and the test shows whether you have glaucoma and if it is stable. As glaucoma gets worse, people can develop additional black spots in their visual field test that correspond to blind spots in their vision. But for many people, it's not that simple to get a dilated eye exam with an ophthalmologist, perhaps because there's no eye care provider close by, or they don't have insurance, or their copay is very high, or someone they knew had a bad experience with the eye care provider that is close by. So because there are so many disparities in the prevalence of glaucoma, where people from minority backgrounds and people who live with limited incomes have a higher prevalence of glaucoma, the National Academy of Science, Engineering, and Medicine issued a call for action in 2016, stating that coordinated efforts are needed to expand public health capacities that recognize improved eye health as an important population health outcome to achieve better health equity. In response to this call for action, the Centers for Disease Control and Prevention provided a grant opportunity to test approaches to improve glaucoma detection and treatment among high-risk populations, and we responded with the SIGHT program, Screening and Intervention for Glaucoma and Eye Health through Telemedicine. This is a community-based telemedicine program with enhanced education, counseling, and support to help participants who screen positive for eye disease attend follow-up appointments. We have received a grant from the CDC to pilot this program in 2 trusted community clinics who have each been providing care for patients in their underserved communities for the last 37 years. Our telemedicine program uses a small screening space in the community clinics, and the ophthalmic technicians take an eye health history and measure vision, glasses, eye pressure, corneal thickness, and take photographs of the back of the eyes along with an OCT test. We are currently evaluating this program to see if placing glaucoma screening programs in community clinics that serve people at high risk of glaucoma, African Americans, and those of older age and with fewer socioeconomic resources, will increase case detection rates over the average of 2% in the wider population. So screening for glaucoma in free clinics and federally qualified health centers using telemedicine, where the ophthalmologist is not physically located at the community clinic but can still provide high-quality medical advice, may be a way to expand the reach of glaucoma screening. So what happens after someone is diagnosed with glaucoma? We know that for 89% of people who are diagnosed, the doctor recommends that they take eye drops. However, do people actually take the eye drops? When we look at glaucoma medication adherence on a population level, we see that about 1/4 of people who are diagnosed with glaucoma never fill a prescription, which often means they're not planning on returning for follow-up care either. About 50% of people who fill their prescription do not take all of their prescribed medications every day. And about 20% of those who want to take their glaucoma medications cannot successfully instill the drops into their eyes. So this makes adherence to eye drop medications for glaucoma the elephant in the room. It is a crucial step to taking control of glaucoma, taking your prescribed medications on time every day, and yet many people are not or cannot do this. So we know that that not taking medications is related to more severe vision loss from glaucoma. Dr. Robin and colleagues demonstrated that those patients who were less than 80% adherent had a 7-fold increased odds of having severe visual field loss. In our laboratory's analysis of 306 participants treated with eye drops from a glaucoma clinical trial, we found that there was a dose-response effect, where the more doses of medication that participants reported missing, the more likely they were to have larger amounts of progressive visual field loss. So why do people have a hard time taking glaucoma medications? In focus groups, patients have identified a number of barriers to glaucoma medication adherence: problems instilling the eye drops, poor knowledge of glaucoma, skepticism that glaucoma will cause future vision loss when it's currently asymptomatic, skepticism that medications will help, other life stress, forgetfulness, side effects, medication cost, difficulty with the medication schedule, and a lack of trust in their doctor. We conducted a study to identify whether there were one or two barriers patients might identify as the obstacle to their glaucoma medication adherence, and we surveyed 190 glaucoma patients. But we found that there was not a single barrier that no one thought was important. Each of the 11 barriers was important to at least 30% of the glaucoma patients. These results made me think of the opening line in Tolstoy's Anna Karenina. All happy families are alike. Each unhappy family is unhappy in its own way. While patients who are adherent share certain common traits, like believing the situation is serious, that the medication will help, and forming habits to integrate taking their drops into their daily routine, patients who are not adherent each have their own unique set of issues that keep them from engaging in their glaucoma treatment that need to be addressed. So, in order to address the issues that are keeping people from taking control of their glaucoma by taking their medication on time every day, we have created the Support, Educate, Empower, or C, Personalized Glaucoma Coaching Program, which we're currently testing in a randomized controlled clinical trial supported by the National Eye Institute. A glaucoma coach trained in listening skills sits with a patient and elicits their unique barriers to optimal adherence. The coach uses a web-based tool that generates personalized content for each patient, so the coach can show the patient their own test results, their own doctor's recommendations, and how other people with similar barriers to adherence overcame those obstacles. The coach uses the tablet like a book. When the coach turns the tablet towards themselves, they can see the prompts written to guide their conversation with the patient. When the coach turns the tablet towards the patient, they can show the patient audio-visual materials to explain glaucoma and address barriers to adherence. In our pilot study of the C program with 39 participants, adherence improved by 21 percentage points after the C program from 60 to 81%. The randomized controlled clinical trial of the C program will be finished in 2025, and we will have the data to understand whether glaucoma counseling should be made a part of standard glaucoma care. So what are some tips for maximizing the control of your glaucoma? To maintain good eye pressure, use your drops at approximately the same time every day. So that means for a twice daily drop, take them about 12 hours apart. For a 3 times daily drop, take them about 7 hours apart. And for a 4 times daily drop, take them about 4 hours apart. And you don't need to wake up at night to take your drops. When you're putting in your eye drops, close your eyes for 1 minute after instilling the drop. That way, more of the medication stays in your eye instead of dripping through the little drain into the back of your throat. This helps decrease side effects that could be from the body absorbing medication intended for your eye. Wait 5 minutes between eye drop medications, as this gets the most strength out of your eye drops by not washing one out with the other. Visiting your eye doctor regularly ensures that your treatment is maximally controlling your glaucoma. I'd like to thank you for your attention and thank my family, my mentors, and my research team for making this work in glaucoma self-management support research possible. I know we'll have time for questions after Dr. Margetta gives her presentation, so I'd like to hand it over to Dr. Margetta.
Thank you so much, Paula, and thank you. That was a wonderful presentation and a wonderful introduction overview of glaucoma, which is going to be very helpful when I get to discussing my things. So let me just open it up here. Are you able to see my screen?
Yes.
Yes. Okay, thank you. Perfect. So my talk, I think, dovetails very nicely with Paula Ann's talk. It's going to be very different, but kind of sort of, let's say, a continuation of what she was talking about. So I will be talking about today glaucoma medications, some of the medications that have been recently approved that you might have heard about or you might be interested in, and also then about therapies in the horizon. So what is sort of coming down the pipeline, let's say, with specific focus on my research, you know, talking about everything that's going down the pipeline could take hours. So I will zip through this because Paula gave a wonderful and amazing introduction to glaucoma, but we know that glaucoma is a huge cause of blindness worldwide, affecting also a very large number of Americans. It is a progressive age-related generation of the optic nerve or the cable that connects the eye to the brain, and the specific cell type that dies is called retinal ganglion cell. And so far, the only risk factor that we can actually change or modify is intraocular pressure. And as Paula mentioned, so basically we have three general types of ways of dealing with pressure: eye drops, laser, surgery, and this is how they all work. And in terms, again, this talk will be focused mainly on the medical treatment of glaucoma, but again, I should add that surgical options at this point for glaucoma are also quite vast, but again, way over the, you know, timeline for this talk. So this is a list of drops, you know, or categories of drops that were available as of a couple of years ago. The point here is not to overwhelm you with pharmacology, but just to say that for a while now, we've had some good choices in terms of glaucoma treatments. You may recognize some of these candidates in red here. But something to note is that many of these medications have been around for a long time and nothing new really had showed up on the market in quite a few years. So latanoprost, which was on that list, the most recent medication, was actually approved more than 20 years ago now. And then 20 years have passed without any new developments in terms of drugs for glaucoma. But then 2017 turned out to be an exciting year for glaucoma medications because FDA approved two new medications, which go by, I'll call them by their brand names, Vyzulta and Repressa, just because they're easier to say, frankly. So what do we know about these medications? How useful are they? Should you be switching to them, et cetera, et cetera? So I'll give you my, personal take on this, but Vyzulta, basically the key thing to know about it is that it is basically a sort of a dual medication. So it's a prostaglandin like latanoprost, but it has this extra sort of group that is a nitric oxide donating group. And what is that thought to do is that it causes relaxation of the trabecular meshwork or the drain of the eye and therefore lowers the pressure. There was a key clinical trial that came out, a couple of years ago, which showed that Vyzulta was more effective than timolol. So this was a direct comparison. So taking Vyzulta once a day was more effective than timolol twice a day, and it was safe. And the specific finding they reported in this trial was an 8 millimeters of mercury decrease from baseline in terms of pressure, which if you have glaucoma, that's pretty good. Normal glaucoma pressure ranges are about 10 to 21. So going, down by 8 is quite a decrease. And the side effects are mainly redness, eye irritation, and dryness, similar with what you see with latanoprost. However, this all sounds spectacular, but an important caveat to consider these results is that actually this 8-point drop that we see with Vyzulta is actually probably mostly due to the prostaglandin part rather than this novel nitric oxide part. And I say this because there was a previous study, a phase 2 study, that actually compared Vyzulta to prostaglandin, and then the difference there was actually much less. It was actually only 1 millimeter mercury on average difference. So that tells you that this fancy addition to the latanoprost actually only, increases the effectiveness by a little bit. Since this actually also happens to be a very expensive medication that is frequently not covered by insurance, I personally find that it's costly and of limited benefit, so I don't tend to actually prescribe it. But the results sound pretty spectacular when you just read about them. So now moving on to the second drop that sort of came on the market relatively recently. This one is called Repressa or Netrosudil. It is an inhibitor of a molecule called Rho kinase, and it's thought to do multiple things in the eye to decrease the pressure, increasing outflow through the drain of the eye, and then also decreasing production of the fluid in the eye. So you basically, again, sort of turn down the faucet and increase the flow through the drain. Again, there was an important study that came out comparing again to timolol, and what they found that Repressa once a day was as effective as timolol twice a day, and again was quite safe. Here, what was noted was about 4 millimeters of mercury decrease from baseline pressures. What I like about this medication, though, is here the novel mechanism of action is completely novel. So unlike Vyzulta, which sort of piggybacks onto prostaglandin, this is something completely different than what we have in our sort of skill set or database of medications. In terms of my experience with Repressa, and Pauline can comment later on hers, I have found that many patients have reasonable responses, and occasionally I'll have a sporadic patient that has a very significant pressure drop. There are some side effects that come along with this. Eye redness is quite common, or usually goes away, but for some people it can be pretty significant. And then you can also get these so-called subconjunctival hemorrhages, which are these little micro bleeds on the white part of the eye. They're not dangerous, but people don't like having them for obvious reasons, cosmetic, nothing else. So not everybody gets them, but some people do. So my personal verdict is I do tend to use it, although it's still for me not a first-line treatment. I still tend to start people on a prostaglandin like latanoprost or Travatan or something like that if I diagnose them with glaucoma. So to summarize this part so far, basically after 20 years, we finally have 2 new glaucoma medications on the market. They both did very well in clinical trials. But I personally find that Repressa is more useful than Vyzulta in clinical practice in terms of both being completely novel, and then again, neither of them are cheap, but at least with Repressa you get something new, while with Vyzulta I feel like it's just more of the same thing that you can get at a generic price. All right, so now moving on to something completely different. So now I'm going to switch gears and talk about glaucoma treatments on the horizon. So as we sort of, again, already mentioned, we have many good medications to control pressure. We have also many surgical options to control eye pressure. But what do we do when eye pressure control is not enough? And I'm not referring here to cases when people are not being adequately compliant, et cetera, which of course is a huge problem, as Pauline, already discussed. But I'm talking about patients who are actually compliant and doing everything they can, and yet nonetheless their glaucoma gets worse. So I have, for instance, a patient who is an 83-year-old woman who has normal tension glaucoma. Eye pressure is remarkably low. She takes her 3 medications and takes them steadily. But yet, if you look at these visual fields that you now know how to interpret after Pauline's presentation, you can see that the amount of black seems to be steadily increasing as we go along. So she takes her medicines, her pressures are low, they're always under 10, which is pretty fantastic, frankly, but yet she's getting worse. So what do we do for a patient like that who's either taking their medicines or they've had every imaginable surgery, and yet their glaucoma is getting worse? So the topic there really then becomes neuroprotection in glaucoma, which is what treatments for glaucoma can we come up with that do not address the eye pressure, but instead act directly to prevent retinal ganglion cell loss. So again, to remind you, those are the cells, neurons that die in glaucoma, and basically what we're trying to save. Obviously, people have tried this for a long time. This is not a new idea to try to directly target retinal ganglion cells. A lot of things kind of look promising sort of preclinical studies. The starred compounds here actually had clinical trials done, and so far none of them have panned out, in terms of truly promising data. So where do we go from here, of course, is the next question. A key aspect is, of course, we can try to improve our clinical study and clinical trial designs, including, for instance, novel imaging techniques that were not used in many of the previous trials. But I would also argue it's important to have better drug target selection. So previously, a lot of these candidates were sort of picked, sort of based on your favorite compound that might have worked for some other disease or that you care about for other reasons. And nowadays, we are starting to use these high throughput screens like RNA sequencing, which I'll go into in a little bit more detail, that allows us to use a more systematic approach towards this drug target selection. I also think it's very important to pay attention to other cells in the retinal milieu, so other cells in the retina, which again is the tissue that gets damaged in glaucoma, in addition to the actual cells that die. And my particular research focuses on a cell type called microglia, which you can think of them as basically the macrophages that live in the neural tissue. So you might not be very familiar with this, so I'll just give you a quick overview. They're this beautiful cell type that kind of are sort of branched out. And what they really are is first-line immune responders in the brain and the retina. They play very many important roles. They're basically constantly survey their environment. They're important for defense and healthy repair. They're important for development. They're important to kind of homeostasis, meaning keeping things in steady state. But it's also been pretty clearly shown they can be very harmful in certain contexts. That once you have tissue injury, they can worsen it by secreting inflammatory and toxic molecules. They can destroy stressed but still living cells, and they basically create this bad inflammatory environment that basically worsens the injury. So in order to study the role of the cell type in glaucoma, basically the way the approach we took was this sort of unbiased approach. And again, don't look at the details here. That's not relevant, like for our purposes. But what I will say is we took these two different glaucoma models in the mouse. We isolated microglia, and basically we were able to get something called RNA sequencing, which is literally this comprehensive list of genes that are either turned up or turned down in glaucoma compared to control condition. And that gives us a list of candidates to basically then go after to see if we can modulate them and change the response in glaucoma. So the key findings, again, there was a shared signature between these two models. And interestingly, the same signature was shared with some of the neurodegenerations in the brain, like Alzheimer's disease or ALS or multiple sclerosis. So that was interesting. It seems like a general response to injury seems to happen regardless of the specific type of neurodegeneration. And one of the key molecules that was increased in both glaucoma scenarios is called ApoE. And this is the molecule I'll be focusing for the rest of the talk, the focus of my research. So what is ApoE? It's a major lipoprotein in the brain. You might have heard of it in the context of Alzheimer's disease, where a particular variant of ApoE is a known risk factor for Alzheimer's disease. Interestingly, that same variant actually seems to be protective in glaucoma, and we can go into this more in the discussion why I think that is. And then also importantly, in the retina and aqueous humor of glaucoma patients, ApoE appears to be increased. So that kind of told us that this might be relevant to human disease. So then the key question whenever you're doing something experimental like this is what happens if we actually get rid of ApoE, what happens to the disease? And there are some wonderful genetic tricks in mouse models by which you can actually get rid of ApoE only in the cell type of interest, in this case, microglia. And you can see here, so each red dot is a retinal ganglion cell, which again is the cell that in whose survival we're interested. So this is our control. We induce high pressure, retinal ganglion cells die, kind of standard glaucoma scenario. But interestingly here, pressure is high, but just because microglia don't have ApoE, retinal ganglion cells survive. And we basically see the same thing in terms of retinal ganglion cell processes and as well as their function. So this was very striking, and it told us, okay, if we modulate the cell type, which is not even the cell type that dies, that is enough to protect retinal ganglion cells and have them survive. The mechanism is really, again, a little bit too complicated to get into details, but I'll just give you a tiny overview. What we think ApoE is doing is basically regulating this response of microglia, specifically to damage their dying neurons. And what we also found is that if you take these activated microglia and actually inject them in the eye, that is enough to cause retinal ganglion cells to die. So basically what you create is this vicious cycle where you might have some initial injury, retinal ganglion cell death, and that causes neuroinflammation, and that then leads to more retinal ganglion cell death. And you kind of end up in this vicious spiral where you could potentially see that, let's say you had high pressure, you cause initial insult, maybe you lower the pressure. Now the insult might keep going even though the initial inciting factor is gone, because you basically set off this deadly cascade in process. And then finally, what about human glaucoma? How relevant is this to human glaucoma? The first starting point can be, of course, just to see if by histology we can actually see these in post-mortem human samples of eyes with glaucoma. And in fact, we do see that ApoE is turned up in glaucoma retinas much more so than in controls, in microglia specifically. So what basically this makes my overall take-home message is, can we then actually try to treat this bad environment where we have retinal ganglion cells that are actually dying, but then this whole retinal milieu of microglia and other cell types that are sort of contributing to this death. And I would like to propose that, again, microglia, especially specifically ApoE signaling, seem to be very important in contributing to this retinal ganglion cell death, and that potentially by targeting this pathway, we could develop therapeutics for advanced and progressive glaucoma. And I will also mention this whole story has focused solely on ApoE, but from that same big list of genes that we now have several other candidates where we see the same phenotype, meaning we get rid of the gene and retinal ganglion cells don't die. So we, at this point, have a really nice list of potential candidates that we could pursue in terms of potential drug targets. So overall take-home points from this talk. To develop new glaucoma treatments, we really need a better understanding what underlying mechanisms of glaucoma. Retinal milieu matters, not just retinal ganglion cells. So we really need to understand the whole environment in the retina, not just the cell itself that is dying. Unbiased drug target selection is important. So, again, not picking your favorite candidate, but, starting with an objective list and kind of working through it. And then finally, I would like to say is that, in my personal opinion, the future of neuroprotective research in glaucoma is bright. We have many new approaches and many new technologies, and I think we will really be able to advance this field and help our patients. And I would like to thank everybody, the lab group that I'm in, my mentors and collaborators, and especially my funding sources, in particular Research to Prevent Blindness Career Development Award, which has obviously been incredibly helpful for all of this work. Thank you.
Thank you so much to both of you for talking today. I think that these two talks have really highlighted two critical challenges in glaucoma. The first is access to healthcare and healthcare delivery in a setting of glaucoma. And the second is actually trying to leverage cutting edge science to understand why people lose vision when they have glaucoma. So fascinating talks. Thank you very much. I already see a couple of questions in the chat. Please put more in as we go, and maybe even the answers will prompt you to have additional questions that you can put in. So I think the first question comes from Mark Pomerantz, and this is directed to Paula, and that is, he has been controlling his glaucoma with drops for 30 years. He now needs cataract surgery with the optional insertion of a drain tube. He's read that the tube may require replacement in 5 years, and he's wondering if it's worth it to go for the tube or should he stay with his drops. He's 79 years old. What can you tell him?
I think it's really important to discuss pretty intensely with your physician what the potential risks and benefits are for your case. Your physician, if they've been following you for 30 years, has seen how well the glaucoma medications have kept your glaucoma under control during this time. I think switching, having a tube put in at the time of cataract surgery is always an option. In my practice, I usually use that for people whose glaucoma is not well controlled with drops. And then sometimes I will use other kind of less invasive surgical interventions to try and reduce drop burden among people who are well controlled with drops, but they may, either wish to reduce the number of drops they're taking. So I think that there's a lot of surgical options right now. And I think, Dr. Margetta, you can also comment on this. I mean, I think the only other thing I'd like to mention is that the 5 years is how long tubes last on average. And so it's really variable how long a tube will last for an individual patient. Sometimes it's less, sometimes it's more. And when we put all of that data into, a database and take an average, it's 5 years. But that doesn't necessarily mean it'll be 5 years for you.
I fully agree with that. I mean, I guess from the aspect of the tube, it's really highly individual. I don't necessarily think of it as kind of you put it in and then it's not like a car that I don't know, if you do something and then 5 years later you have to do an oil check or something. 5 years later you have to have the tube replaced. Some people might have issue with their tube and they might have to be removed. There's people also who had it for longer periods of time and they do just fine. So my bigger concern, and of course we need to have a little bit more clinical information, is, there's as Paula mentioned, there's risks and benefits. So I guess my key question is your glaucoma stable or not? If your glaucoma is stable, then it's really sort of the more nuanced decision, okay, you need the cataract surgery. If you put the tube in, you might be able to get off some of your drops, which of course might improve your quality of life, but there's always risks the more complex surgery you're doing. So that's one scenario. If your glaucoma is actually not stable or doing worse, then I definitely would say it's a good idea that, you have something else done because you need it. Clearly the drops are not doing their job. So it's a little hard to comment fully without having all the clinical information, but what I would say is you need to have a good discussion with your doctor, I guess.
Great. Okay. The next question is from Rebecca, and that is, and I think again to Dr. Newman-Casey, because this is about your program, are there any materials in the SEED program to support parents of children with glaucoma, which is an especially challenging role for parents?
That's an enormously challenging area. And I do not have, I have discussed this with a couple of pediatric ophthalmologists, the need that we have to develop content for parents and, older kids with glaucoma. We have discussed it and we haven't actually done it. So I'm sorry to say we do not have good content for you at this time. I hope that will change in the future.
Great. Okay, Linda Panuto asks if there's a relationship between glaucoma and RP, which is retinitis pigmentosa. And Melissa, do you want to take the answer to that, and then back to
I mean, I can try. I don't think there. I mean, feel free. Everybody here, feel free to chime in. I don't think there is we don't think of that there being a strong relationship between the two diseases. Glaucoma, in most cases, is an aging-related disease, and the cell type that dies, as I mentioned, is the retinal ganglion cells. So that's basically the last relay stop in conduction of visual information to the brain. In retinitis pigmentosa, there are again some exceptions. There are childhood glaucomas, but again, they tend to present pretty differently than RP. RP is typically the generation of the outer part of the outer segment of the eye, so photoreceptors, and is typically strongly genetically linked, and is typically diagnosed in younger ages, so sort of teenagehood and all of that. They do share some similarities in the sense that in some types of RP, you kind of also get peripheral vision loss. So from that perspective, they're similar. But again, we think of them as pretty different clinical entities. Now, I would like to argue, maybe based on some of my research, I'm a little bit biased. What I study is, of course, neurodegeneration and glaucoma, but some of the mechanisms we're finding the commonality seems to be any type of neurodegeneration. So potentially the types of things that I'm looking at research-wise might have relevance to other types of neurodegenerations like RP, but that's still very, very speculative. But I don't usually think of them as being the same bucket. Paula-Ann, I don't know if you can add more to that.
No, I don't think I have anything to add. I think you did a great job explaining, the potential similarities, but in general, fairly different buckets.
Great. The next question is again from Rebecca, and I believe this is probably also to Dr. Margeta. Can you comment on whether or how ApoE and microglia may change when looking at glaucoma caused by inherited forms of glaucoma, such as through a loss of FOXC1 gene? Would the efficacy of a treatment like this change if there were also structural issues in the eye?
That's an interesting question. So remind me, you guys, FOXC1, that's typically childhood glaucoma, right? Pediatric glaucoma, if I remember correctly. Am I remembering that? Well,
yes.
Sorry, I don't see children. So if I sound a little bit rusty, that's probably why. So I guess genetically speaking, I would think of them as being very similar. Again, the most childhood glaucomas typically, again, are caused by some sort of problem in the drain of the eye. So the drain of the eye doesn't work well, pressure is high, typically very much, from childhood early on, even from, it can be diagnosed in infancy. And then the pressure is typically very high, the eye can get large, you get ophthalmos, et cetera, et cetera. So that is oftentimes when it can be diagnosed, it can be pinpointed to a specific genetic defect that causes maldevelopment of the outflow structures of the eye. ApoE itself does have genetic variations, although the common variant, the one we most have, would probably be just baseline risk. And then I kind of hinted this in the talk, the genetic aspects. Interestingly, the rare variant, which is ApoE4, actually seems protective in glaucoma. So, having that might be bad for Alzheimer's disease, but it might make you less likely to get glaucoma. So that's kind of like a separate thing. But in terms of would neuroprotective treatments work in childhood glaucoma, which I think the second part of the question asks, I would say yes, because most of these neuroprotective treatments, basically, they're not asking, for that purpose, it almost doesn't matter what is causing the high pressure. Is it development? Is it aging? Is it, pseudoexfoliation? Is it some other type of glaucoma? What it gets to is really how the cells are dying in the back of the eye. So I think in principle, neuroprotective therapies would be applicable to childhood glaucomas, although they probably won't be tested first in those types of cases simply because there's not that many patients with that. Primary open angle glaucoma is much more common, but that would be my answer to that.
Great. So Rebecca actually put it's Axenfeld-Rieger's, so it likely would be
Thank you.
Earlier age.
Thank you. Okay, it doesn't change my answer, but thank you for clarifying that. I clearly need to read up a little bit on my, genetics of, developmental glaucomas. Again, I don't see pediatric patients, so I get a little bit rusty. But what I answered is basically similar type of thing where, Axenfeld-Rieger is typically, again, issues with the front of the eye working properly. But from the perspective of neuroprotective therapies, that doesn't matter so much, like whatever is causing the high pressure, the key thing is to try to make retinal ganglion cells not die because of that pressure.
So great. The next question is from Diane Swift, and that is, how great is the hereditary component in glaucoma? And I'll let either one of you answer that one.
Paula Ann, why don't you try first, and then I'll try to model.
Emily, so you might have more insight into this, but from what I can tell, in terms of adult onset glaucomas, which is what Dr. Margetta and I have been discussing today, really, the hereditary component is not clear. And there is clearly a hereditary component in that glaucoma runs in families. And if your parent or your grandparent has glaucoma, you're much more likely to have it, but you won't necessarily get it. It can skip generations. It's not clearly like, if your mom has glaucoma, all of the kids will have glaucoma. So it's not a clearly hereditary disease in that this just kind of Mendelian way. So there's clearly hereditary components, but then, there's this question of why doesn't it affect all the people in a family? And so it's fairly complicated how glaucoma may be passed down genetically, because there are many, many, many genes that have been implicated as potentially involved in different mechanisms in glaucoma. And so, I don't know, Dr. Margetta, do you want to discuss the US
I think
studies?
that's a wonderful summary. I guess maybe the one could differentiate here again between childhood developmental glaucomas and adult glaucomas. In childhood glaucomas, it's much more likely to be what Paula Ann referred to as Mendelian, meaning, I don't know, if a parent has it, your child might have a 50% or quarter chance percent of having it or whatever. So it follows a particular pattern. That is much more the case for childhood glaucomas, in the adult glaucomas tend to be many, many genes working together. So yes, there's a genetic component for sure. But again, as Paula Ann said, it's not like, oh, my parent had it, I will for sure have it, or I have it, therefore my children will have it. But it does highlight the importance of screening. So I'll just kind of send it back to you, because Paula Ann was saying how important it is to screen, especially if you have family history. So for instance, if somebody in your family does have glaucoma, I think it's very prudent to get your eye exams and kind of not ignore it. And, this does happen. For instance, I saw recently, a youngish patient in her 40s. She only came to see me because her mom is a patient of mine and has glaucoma. And she actually had pretty significant glaucoma and was shocked. I mean, she kind of expected me to say, oh, you're fine, see you in a couple of years, but she actually had pretty bad glaucoma. So thankfully she did come in and get screened. So again, it's not, having family history is not destiny, but I think you should take it seriously in the sense of getting screened, just to make sure.
Great. So the next comment is by Elizabeth Vonner, and she says that the Childhood Glaucoma Research Network has information about pediatric glaucoma for both parents and caregivers, and gives the web link in the chat. So in the Q&A, if you're interested, please copy that link for access to information to help parents with children with pediatric glaucoma. Please feel free to type your questions. I have a question actually for Dr. Newman-Casey, and that is that with the community approach that you described, that's actually really exciting and I think very important, because healthcare delivery is such a challenge for many underserved groups. I have many overserved groups too. I think just getting to the doctor as often as needed. Are there any telehealth lessons that we can learn from COVID that could be harnessed to help us in the future to better deliver glaucoma care? I mean, to me, the big challenge is you can't measure intraocular pressure in a remote setting, but have there been any learnings that you would have that will help patients?
Thank you so much for asking that question, because I think what happened in our case is the opposite. Which was great. We were already running this community-based telehealth program before COVID started. And so we said, hey, what can we learn from our community-based telehealth program to help us figure out how to deliver care during COVID when we want a low-touch system and a low-volume system? So the way that we run the program in the community clinics is pretty low volume. The technician sees 5 patients a day. It's not a lot. The technician is completely outfitted. So they have tonometers, pachymeters. They have they can do refraction. They have an OCT. They have a fundus camera. They have all the equipment to fix glasses. So they're running like a teeny tiny little eye clinic. And just, I feel like I'm the man behind the curtain, and I'm just kind of reading all the images and telling people what to do, but nobody ever sees me. And when the patients actually come in who screen positive for being glaucoma suspects, and half the patients I see in our free clinic on Saturdays. So I'll see people and they'll say, "Where's the technician?" So they, have no idea who I am, which is wonderful. And I think the model, so just to actually answer your question, what we started at COVID at Kellogg was we then took this model of what we ended up calling virtual plus. So you're right, you really cannot monitor glaucoma without pressure, without fields, without OCT. Like, we need objective data to make informed decisions about whether or not pressure is controlled. And so we started kind of offloading the volume of the clinic, because really what we wanted to do during COVID is not have people in our waiting rooms. We didn't want to have the normal 2-hour wait in my waiting room that seems to occur, no matter how hard I try. So, what we started was just having spread out visits with the medical assistant, where people would come in, get their vision checked, get their pressure checked, and I would just put in what I wanted done. Did I just want a pressure? Did I want a pressure in a field? Did I want to, pressure in an OCT? And people would come in and get their testing done, and then I'll have a phone or video appointment with them the next, a couple days later. So that's how we kind of took what we set up in the community and kind of brought it into the eye center during COVID.
That's great. And I think that a lot of people moan and groan about COVID. Oh my God, it's so awful. But I really do think that there are things like this that we can learn that's a silver lining to COVID, and going forward, patients will actually receive better care because of the innovation that people have done during COVID times. Brian, I have one more question for Dr. Margeta. Do I have time to ask that?
Sure, go ahead.
Okay. So my question for you is a question that I think a lot of people have for innovative, novel therapeutics going forward. And that is, when could somebody expect that might be available for them? And I know it's a tough question to answer, and I think about it a lot because I develop drugs for things.
You're probably better suited to answer that question than me at this point, but we can attempt to answer. Honestly, frankly, again, you will be better suited. I am still at the point where it's really more discovering the concepts rather than thinking very concretely about the practical translatability, but in my mind, right now we're of course doing this in a model organism because you can prove things very nicely in the model organism. Sometimes people will prefer also then to have a next stop in terms of trying the treatment, in like a primate model, and then, the actual human trials can be fairly sizable and expensive and take a long time. So my gut feeling is that unfortunately, this is not something that you can develop immediately, that we're talking more about years, maybe a decade, and even that might be optimistic. But I don't want to be, what do you think, since you're actually actively trying to do this in your professional work?
I would say a decade to 1 to 2 decades. And that's not because there's not a lot of great ideas. It's just because of some of the challenges you pointed out earlier. And it's really hard to understand if you're making an impact on the disease, and then if that, is ultimately of benefit to patients. But the first step, and actually I would argue the hardest step, is the work that you're doing right now, which is identifying good targets for a therapeutic intervention. So thank you very much. All right, Brian.
I wish it was faster, but alas, I feel like if we don't start now, hopefully if we start now, then, in some years, we're actually going to have something to show, so that's what we're trying for.
Absolutely. So Brian, we are 10 seconds. I'll hand it back to you.
Great. We're at the end of our hour. I want to thank our 2 speakers for wonderful presentations. Thank you to Dr. Grosskreutz for a great job of moderating. And thank you for all the audience participants who asked questions and for joining in on this first Lunch and Learn session. And also, again, thank you for providing support to RPB to help make this research happen. So just thank you to everyone. And I guess we could stay on for a couple of minutes if there are any other questions that people would like to ask, but we are at the end of our hour. I guess one question I have for both of you, both of the speakers, is could you just give us a thumbnail sketch of where you see your research going next from here?
Sure. So I think right now I'm focused on kind of the initial development and testing of programs to address access and treatment of glaucoma on a population level. So how do you access glaucoma care? And then also, how do you support people to take their medications and come back for treatment once they've been diagnosed with glaucoma? Trying to really reach the 25 to 50% of people who are not currently being treated or well treated. And I think that where I'd like to go, should the C program be successful in a randomized controlled clinical trial and demonstrate that there really is improvement in patient adherence to medication regimens when given adequate personalized support. The next phase for me would be doing a multi-site clinical trial to evaluate whether this type of enhanced self-management support by trained non-physician glaucoma counselors would change the trajectory of visual field loss in glaucoma. I think that's just like Dr. Margetta is looking, these long-term outcomes, which, IOP is a surrogate marker of how well glaucoma is controlled, but really, field of vision loss is when the disease starts affecting people. So I'd like to see if changing behavior and helping people to change their own disease self-management behavior impacts vision loss. So that's probably my next step in kind of developing the infrastructure to facilitate scaling the program nationally.
Wonderful. So I guess when I think about future steps, this is obviously still very much an evolving work, but the ultimate goal of everything I do would be hopefully for it to at some point result in a new neuroprotective therapy for glaucoma and possibly other neurodegenerations. In a more concrete level, what we have done so far is I think really highlight the importance of the cell type microglia in glaucoma, with ApoE being a key player that we found. But of course, as I already mentioned, there's multiple other players. So on one hand, we really want to understand better mechanistically what is happening, how these molecules are acting and how they do what they do, because that's going to be important, again, in terms of developing therapies. We also want to test out therapies where they're available. So one of the other molecules that I didn't talk about today, there's already, commercial inhibitors available. So that's one of our future experiments to try to inject that in the eye of glaucoma. This is in a mouse model again, and see if that's enough to prevent neurodegeneration from happening. If that's a positive result, that would of course be very exciting in terms of pursuing that type of thing, further as a developmental therapeutic strategy. We would also like to know, in patients, can we identify patients who would be appropriate candidates for this? Look at biomarkers, look at levels of some of these molecules in the aqueous or in their, in their bloodstream to see how well can we correlate what we see in the animal model with what we see in the human. So it's a lot of different pieces, but again, the overarching goal would be to really try to identify a good target and then hopefully develop a therapy that would be based on that target.
Great, well, thank you. And there was one unanswered question, which I'll just throw out from a participant, Z. Anna Payne. What is the difference between open angle and closed angle glaucoma? And is the information that you presented applicable to closed angle glaucoma? And just said, great presentation.
Who is that one for? Or I guess either one.
I think either of you.
I mean, I can start. So closed angle glaucoma has a different pathophysiology than open angle glaucoma, but the end result is the same, which is that if it's untreated, there is degeneration of the optic nerve that needs to be addressed. The treatments for open angle and closed angle glaucoma, at least the initial treatments, are somewhat different. Closed angle glaucoma is an anatomic problem where the drain of the eye is physically too narrow for the fluid to drain properly. And so you need to have either a laser or surgical intervention to reposition, so to make the iris fall away from the inside of the drain. And so, medications may be needed in addition to the surgical intervention if the closed angle glaucoma had been going on for some time. But it's a different pathophysiology. If the closed angle glaucoma goes on for a long enough time, the optic nerve will degenerate just like it does in open angle glaucoma. And then you'll end up with the same issues that you have in open angle glaucoma with nerve degeneration requiring treatment. if you're just coming in for an evaluation, we always look at your angle to see what the mechanism is of your glaucoma to try and find out what is the best treatment for you. The reason people talk about closed angle glaucoma is because if someone is suspicious for developing closed angle glaucoma as they get older, because the lens inside the eye grows thicker as we age and takes up more space, pushing the iris forward, and can make the drain of the eye narrower if you're anatomically predisposed to something like that, we can do what's called a peripheral iridotomy, which is a little laser hole in the iris, which then just equalizes the pressure between the front and back of the eye and kind of allows the iris to fall away from the drain and allows the fluid to flow better. So there is different treatments for the two. They have different pathophysiologies. In terms of Dr. Marghetta's work, if somebody ends up with advanced glaucoma from either mechanism, we still need good therapeutics to lower IOP and to protect the retinal ganglion cells once we've kind of gotten to that point.
Great, thank you. And we're over our hour, but I just wanted to make sure that all the questions were answered. A couple of comments just saying thank you for great presentations. I would echo that. So Dr. Newman-Casey, Dr. Marghetta, Dr. Grosskreutz, thank you again for, you really embody, I think, the ideal of clinician scientists, both in terms of treatment of glaucoma, but also doing very important groundbreaking research. Thank you very much.